In Module 5, we will concentrate on discussing the evaluation of infants with BPD. The learning goals for this module is to recognize the laboratory, radiographic, and other imaging features for infants with established BPD. However, before we discuss specific evaluations, we first need to stress that BPD is not an isolated disease, but rather a multisystem problem. The cardiopulmonary issues in BPD infants and a long list of other issues in the same infant would affect each other, and the interaction of lung disease and these multisystem issues will affect the long-term pulmonary and neurodevelopmental outcomes in these babies. Therefore, we advocate for a comprehensive multisystem evaluation approach. In addition to the evaluation for cardiopulmonary disease, which we will discuss in more detail in the rest of this module, pulmonary mechanics needs to be carefully evaluated through clinical observation, ventilator graphic assessment, and if available, by formal pulmonary function testing. Equally important is the evaluation of other system problems that might affect the progression of the lung disease. These include careful assessment of patient's growth and nutritional status, presence of microaspiration from either oral feeding or GE reflux, fragile bones or existing fractures, and other potential causes of lung disease. For example, these two pictures demonstrate aspiration and pulmonary soiling in two patients. On the left, aspiration resulted from uncoordinated oral feeding. On the right, H-type TE fistula led to chronic pulmonary soilage. In the next few slides, we will discuss the cardiopulmonary disease evaluation in more detail. First, let's talk about lung imaging. Chest X-ray is by far the most commonly used imaging tool in the evaluation of lung disease. Chest X-ray findings in BPD vary by disease severity and stage. In the early phase on the left, chest X-rays of many infants with BPD or evolving BPD show a homogeneous granular or ground glass pattern. Compare the chest X-ray on the left with the one on the right. Please note that over time, a more heterogeneous pattern with diffuse haziness, coarse interstitial densities, and cystic-like structures may appear. Lung volumes on chest X-ray may be normal or low in infants with mild to moderate BPD, but can be reduced or severely hyperinflated in infants with severe BPD. In addition, airway and cardiac anomalies such as megatrachea caused by chronic distending pressure and cardiomegaly can be seen in some patients with severe BPD. Although bedside chest X-ray is a convenient tool and it is available in most centers, it is not very sensitive in delineating the details of lung disease. High-resolution computed tomography provides three-dimensional spatial resolution compared with conventional radiograph. However, radiation exposure from CT is substantially greater than chest X-ray. To reduce the level of radiation exposure, novel scanning algorithms have been developed in some centers. For example, ultra-low-dose CT-angiogram protocols available in some institutions is able to decrease CT radiation to the level of 3 to 5 bedside chest X-rays. Even at this lower radiation dose, CT is still much more sensitive in detecting structural abnormalities in the lungs than plain chest X-ray, as you can see when comparing the chest X-ray on the left to the low-dose CT from the same patient in the middle and on the right. Common CT features that can be seen in the infants with severe BPD include atelectasis, parenchymal bands, air trapping, intercostal bulging, and subpleural triangles. Several other imaging modalities are also used to evaluate lung disease, each with its own advantages and limitations. However, data to support the utility of these modalities in the BPD population are limited, and techniques suitable for these patients are still being developed. Please pause the recording and review the use and limitations of these imaging modalities. Nevertheless, These imaging tools can be helpful in certain difficult cases, like in this patient with a severely hyperinflated right middle lobe. Decision for right middle lobe resection was made after perfusion scan overlaid with SPECT CT demonstrated markedly decreased perfusion to the right middle lobe. As research in this area progresses, more data may be obtained to guide clinical management and help to predict long-term pulmonary outcomes. As we have discussed, airway abnormalities can play an important role in the clinical course of infants with BPD. However, timely and accurate evaluation of the airway abnormalities in a young infant with little pulmonary reserve can be difficult. In addition to the radiographic tools, bedside or OR endoscopy evaluation of the airway can be very helpful and usually well tolerated. NPL can be easily done at the bedside with minimum or no sedation to evaluate the larynx and the vocal cord. However, examiner experience can greatly affect the accuracy of the evaluation. Rigid bronchoscopy provides high-quality, magnified images of larynx and subglottis, and the airway can be assessed simultaneously for diagnostic purpose and therapeutic intervention. However, it usually requires general anesthesia in the OR and cannot evaluate beyond the main bronchi. In contrast, flexible bronchoscopy can be done either in the OR or at the bedside and can provide dynamic evaluation of the airways, as paralysis or deep sedation is usually not required. Next, we will discuss evaluations for pulmonary vascular disease, and let's focus on the commonly used evaluations for BPD associated pulmonary hypertension, that is cardiac cath, echo, and BNP. To date, cardiac catheterization is still considered the gold standard for the diagnosis of pulmonary hypertension. It can provide pulmonary vascular hemodynamic measurements and direct visualization of pulmonary vasculature narrowing, dilation, or pruning. In addition, vasodilator responses can also be assessed by applying oxygen and inhaled nitric oxygen during the procedure. However, consider the invasive nature of the procedure, the post-procedure complications, and the instability of the BPD patient. This procedure should only be performed in centers with adequate resource and experience in handling cardiac cath for infants with severe BPD. Even in experienced hands, the risk and benefit of cardiac cath needs to be carefully evaluated prior to the procedure. Compared to cardiac cath, echocardiogram is a relatively non-invasive screening tool. The echo assessment of pH relies on evidence of elevated pulmonary artery or right ventricular pressure. In addition to estimating pulmonary pressure through tricuspid regurgitation jet, echo mainly uses indirect signs such as septal positioning, RV hypertrophy, and RV dilation as indications of elevated PA-RV pressure. However, there's no unified standards for the echo assessment of BPD-associated pulmonary hypertension. In addition, the echo images are often limited by lung disease and also influenced by individual techniques. Further, tricuspid regurgitation jet is often absent in this population. One study found that only 61% of echo studies could quantify TR jet in infants with BPD, and echo correctly determined severity of pulmonary hypertension in only 47% of cases as compared to cardiac cath. BNP is released by ventricular myocytes in response to stretch. It is secreted as inactive precursor pro-BNP and cleaved into BNP and N-terminal pro-BNP. Both BNP and NT-proBNP are used as biomarker for pulmonary hypertension, and some data suggest that these levels correlate with BPD severity and mortality in BPD patients. For example, in a study of 36 patients with BPD-associated pulmonary hypertension, Kuna and colleagues found that the peak BNP level was significantly lower among infants with BPD-associated pulmonary hypertension who survived than among those who died. Although BMP level is not specific for RV stress or pH, and it should not be used in isolation, serial BMP measurement may be helpful in monitoring disease progression, response to the therapy, help with decision-making, and may also decrease the overall number of echo performed. This concludes Module 5. Thank you for your attention.
We would like to acknowledge the American Academy of Pediatrics, the Organization of Neonatology Training Program Directors, Neo Reviews, and Abbott Nutrition for their support of this educational program. This concludes this module.